Welcome back, auditors and coders, to another explainer session of Decode Healthcare with Harshal. I'm absolutely thrilled to have you here for part 3 of our 10-part training series. Today, we're diving deep into a topic that literally makes or breaks your evaluation and management leveling, which means it directly impacts both compliance and revenue. We are talking about the critical difference between actively managed care and incidental comorbidities. You know, when you're looking at a massive, complex patient chart, knowing exactly what counts toward the complexity of problem addressed and what doesn't is absolutely your superpower. So let's get right into it.
Here is our playbook for today. First, defining the addressed problem. Second, MEET, documenting active management. Third, identifying unmanaged incidental comorbidities. Fourth, a step-by-step chart audit. And fifth, the auditor's summary checklist.
Section 1. Defining the addressed problem. What really counts in E&M coding?
Okay, so the absolute most crucial point here is that a problem is only truly addressed if the provider evaluating the patient actually initiates active evaluation or treatment during that specific encounter. It's not just about the condition simply existing. It's about the provider actively using their clinical skills to deal with it today. And notice this carefully because it's a game changer. Even just considering further testing or treatment, say, maybe electing not to do a procedure because the patient is too high risk, that still completely counts as addressing the problem.
Now, here is a massive trap that a lot of coders fall into. Simply dropping a laundry list of problems, diagnoses, or symptoms into the medical record will absolutely not increase your level of service. If a provider just mentions a past medical issue, or if another professional is managing the problem and the current provider isn't doing any additional assessment or coordination of care, you cannot count it. Referring a patient to another physician without doing your own history, exam, or diagnostic consideration, that does not qualify as being addressed today.
Section 2. MEET, documenting active management, the auditor's anchor.
We know what an unaddressed problem is in theory, right? But how do we actually spot it out in the wild? Well, enter the MEET criteria. As auditors, your eyes should immediately start scanning for the MEET. This acronym brilliantly illustrates active management. M is for monitoring. Are they observing signs, symptoms, or disease progression? E is for evaluating. Are they reviewing test results or checking medication effectiveness? A stands for assessing or addressing. Are they discussing ordered tests, reviewing past records, or counseling the patient? And finally, T is for treating. Are they prescribing or modifying medications and therapies? If you can find the MEET, you have found an actively managed condition.
Time for a major coder pro tip. Please do not just skip straight to the end of the note. Providers aren't restricted to documenting their management solely in the assessment and plan. Evidence of management can literally be documented anywhere in the clinical note. You might uncover a brilliant piece of evaluation hiding right there in the history of present illness, or maybe a key monitoring detail tucked away in the physical exam or chief complaint. You really have to read the whole story to get the full picture.
When you're scanning that chart, you need to be actively hunting for specific green flags. Is the provider stating the severity of the condition? Words like controlled, stable, unstable, or worsening are absolute gold. Are they modifying therapy or continuing a current regimen? Even just renewing a prescription totally counts. And of course, ordering condition-specific labs or diagnostic studies is basically a flashing neon sign that screams active management.
Section 3. Identifying unmanaged incidental comorbidities, knowing what to exclude.
So, having defined what counts, we now have to turn our analytical lens to the exact opposite end of the spectrum. We need to identify the incidental conditions that do not impact your medical decision-making complexity. The crux of the matter is the difference between active and passive care. Managed care requires active clinical decision-making today by the provider reporting the service. Unmanaged conditions? Those are just passive historical mentions. If a note says, do a dental ulcer, we'll follow up with GI, but the provider didn't examine the abdomen, didn't ask about symptoms, or didn't prescribe medication for it, well, it's just a passing thought and definitely does not count towards complexity.
Section 4. Step-by-step chart audit. Breaking down a multi-problem assessment and plan.
All right, let's roll up our sleeves and put all this theory into practice. We are going to carefully deconstruct a single patient's chart, going condition by condition. The provider has listed 4 different items in their assessment and plan. Our job is to apply that MEAT framework we just talked about to determine what actually counts toward the final MDM level and what is just fluff.
Let's look at the first 2 conditions here. Condition 1 is a hypertensive disorder. The provider notes, return to clinic in 2 weeks for BP check. increasing lisinopril from 10 to 20 milligrams. So, what's our auditor verdict? This is managed for sure. Increasing the dosage clearly demonstrates an actively managed, uncontrolled chronic condition. That's the T in meat for treatment modification. Moving on to condition 2, which is anemia. The note says, we'll recheck H&H to ensure stability. Orders, CBC, CMP. Verdict, managed. Ordering specific diagnostic labs covers both the M for monitoring and the E for evaluating in our meat framework.
Now let's check the final 2 conditions for this exact same patient. Condition 3 is diabetes mellitus. The note reads, A1C 5.3%. Continue on current diabetic regime. What do you think? Yep, it is managed. Even though they didn't change the medication, they evaluated a recent lab value and made the active clinical decision to continue the current treatment. That is a perfectly managed, stable, chronic condition. But now, look at condition 4, ulcer of duodenum. The note simply says, we'll follow up with GI upcoming. Our verdict? This is an unmanaged comorbidity. It's just a passive handoff. There's no local evaluation, no treatment, no labs ordered by our provider today. We absolutely do not count this toward the MDM complexity. See how clear it becomes when you just break it down step by step?
Section 5. The Auditor's Summary Checklist. Quick tools for chart reviews.
I highly recommend you mentally pin this checklist right to your workstation. Whenever you are reviewing a chart, just run through these 4 steps. First, filter out the passive history from the active clinical decision-making by determining exactly which conditions were managed using your meat criteria. Second, identify the specific type of those managed conditions. Are they minor, acute, or chronic? Third, if they are chronic conditions, look for those buzzwords to verify if they are stable or uncontrolled. And finally, if they are acute, determine if they are complicated or uncomplicated. Methodically doing this guarantees your accuracy every single time.
And just like that, that wraps up our deep dive into managed versus unmanaged conditions. But as we leave today, I want you to really ask yourself a question. Do you know the exact time frames that officially separate a self-limiting acute illness from a long-term chronic disease? Well, we are going to crack that exact puzzle in part 4 of our series, where we tackle acute versus chronic conditions and why those time frames matter so much in your documentation. Until then, keep applying that meat framework out there. Happy learning, happy coding, and thank you so much for watching this explainer from Decode Healthcare with Harshal.